All righty, welcome everybody to today's presentation on advanced care planning. My name is Ariel Green and I am the caregiver support and education specialist at Care Partners. So some of you all probably got a call from me yesterday as well as an email. We are so happy that you're here and so grateful that you were able to pivot to Zoom and hopefully walk away with some really, really good information. So I'm going to turn it over to Lynette so that she can do an introduction. She is with Messiah Lutheran Church and the host of the presentation, and then I will do the introduction for our speakers. So Lynette.
Just welcome to everybody. We're so glad that you could be with us today. We had really hoped we would be in the fellowship hall and having lunch together. And maybe the next time we can do that. But unfortunately, a big part of our team was affected by COVID this week, and we just didn't feel like it was a safe thing to do. We're trying to be cautious for everybody. So we are very grateful for the flexibility of both Ariel and Allison and Danielle for making the switch over to Zoom pretty quickly, and for you as well. So thank you. We appreciate that very much. I look forward to this presentation. This is information that I need and looking forward to. So, I see we have a few new folks coming in as well. So welcome everyone. I'm going to turn it back over to Ariel.
Awesome. Thank you so much, Lynette. And it's so nice to meet you. We've talked on the phone for it feels like forever. So it's really nice to put a face with the name. So thank you so much. So, okay, so I'm going to introduce our speakers for today. Today we have Allison and Danielle. We're very, very excited to have them. Allison Porch is 6 months into her 1-year physician assistant's residency in geriatric medicine at the Michael E. DeBakey VA Medical Center. She graduated with honors from Baylor College of Medicine's PA program in December. Congratulations to you. In December 2021. And prior to this, she attended Vanderbilt University, where she graduated with a BS in Spanish. And then we have our second speaker, Danielle. Danielle Chan is currently also completing her 1-year physician assistant's residency in geriatric medicine at the Michael E. DeBakey VA Medical Center. She graduated with honors from Baylor College of Medicine Physician Assistance Program in December 2021. Congratulations to you. And prior to this, attended the University of Texas at Austin, where she graduated with a BS in honors of Advanced Nutritional Studies. So welcome, Allison and Danielle. We are so happy to have you. And I will turn this over to you, Allison.
Okay, so thank you everyone for joining us. I'm gonna share my screen real quickly and we can get started. Okay. Can everyone see a PowerPoint presentation?
Yes.
Okay, excellent. All right. So this is a topic that's very relevant, of course, for Danielle and I in our residency in geriatrics. And so we were delighted to be able to share this information that we think is very, very important for everybody. And so that being said, I'll go ahead and get started. Okay. I just figured out I have to click to make it go. Okay, so to start off, objectives for this talk. So we hope that by the end of our discussion today, you all will be able to recognize the importance of advanced directives, understand the purpose of common advanced directive documents of many types, and also to be comfortable with the role of surrogate decision-making. Okay. So I wanted to start off just by going over kind of what exactly advanced care planning is. You'll often see the abbreviation ACP. So this can be used kind of loosely and can be an umbrella term for a lot of things. So, but ACP, advanced care planning, is the process of planning for future medical care in the event that an individual or the patient is unable to make his or her own decisions. So this is a complicated process, but one that's really, really important. It involves exploring, discussing, articulating, and documenting his or her preferences, and helping the patient identify and clarify their personal values and goals about health and medical treatment and what fits and kind of is consistent with their preferences. It also involves identifying types of care that one would or would not like to receive in certain situations down the line in terms of healthcare. And lastly, it involves designating someone else to make healthcare decisions on the individual's behalf in the event that they can't do so for themselves in the future. So just a kind of a distinction here, an advanced directive is an actual record of the process of advanced care planning. So advanced care planning is a whole process of planning, right? And then advanced directive is the like physical record that is completed during that process. Okay. So wanted to talk a little bit about why this is important. A big reason is has to do with chronic disease in the United States. So a chronic disease is a condition that lasts for a year or more and requires ongoing medical attention or limits activities of daily living or both. So many of you might be familiar with activities of daily living, or as we often abbreviate it in geriatrics, ADL. So this is bathing, feeding yourself, grooming, toileting, transferring, and ambulating, walking. So in the United States, 6 in 10 adults have a chronic disease, and 4 in 10 adults have 2 or more chronic diseases. Chronic diseases are the leading causes of death and disability in our country. And also, kind of second to that, adults are living longer. So just to give you an idea of that, in 2018, the number of Americans over 65 in the US was about 52 billion, so about 16% of our population. It's projected that in the year 2060, the number of Americans over 65 will be about 95 million, so about 23% of the population. And then kind of looking at it another way, the US life expectancy in the year 1950 was 68. And about 5 years ago in 2017, it was 78.6. Right. So, you know, this is projected to continue increasing. And so with that being said, there's this increasing requirement of caregivers inherent because there's so many more people living longer than they used to with more chronic disease. And so that increases the requirements of caregivers. I found this pretty interesting and eye-opening. The most recent study we could find was done in 2010, and it looked at adults that were 60 and up who died in the US between 2000 and 2006. So of these, 42% of them required decision-making about treatment in their final days of life. But interestingly, the majority, about 70%, lacked decision-making capacity. And of those without capacity, about a third of them did not have advanced planning directives. So in other words, they did not have their preferences mapped out. They did not have someone that they had designated in advance to make decisions for them. Sorry, I lost my mouse there for a second. Okay, so the benefits of advanced care planning, obviously completing the advanced directive, right? As I said before, it's a record of the advanced care planning process. There's also better understanding between clinicians, families, and the patient with this increased transparency. There's a reduction in end-of-life hospitalizations. There's an increased use of hospice. There's more incidents of patients that are passing away in their preferred place, right? So for example, at home instead of, in a hospital. There's a reduction in costs of end-of-life care. There's improved satisfaction in quality of care, and also decreased stress, anxiety, and depression, and in surviving relatives. And so overall, people who document their preferences are in this way are more likely to get the care that they want and prefer at the end of life versus the people that do not. So who does this apply to? Obviously, this applies to everyone, but for purposes of this talk, especially the elderly, so our people that are over 65 years old, also those with a life-threatening illness, right? You don't have to be over 65, certainly to have a life-threatening illness. It's also especially important when a desired healthcare proxy is not a family member or a spouse. So this slide kind of talks about where we stand in the U.S. today in terms of legality and state versus federal and what that looks like. So overall, the U.S. has some of the highest rates of completion of advanced directives, though it's still around 37%. So this was according to a 2017 study, and this is about 1 in 3 adults in 2017 had completed some form of advanced directive. And in terms of legal authority, there's variation between states. All 50 states in the US have laws that address decision-making. So that can kind of complicate things for patients, and not only patients, but also providers with access in various states. So if someone designates an alternate decision maker, right, they're designating that person is a surrogate decision maker. So it's someone that they choose before they become incapacitated to make decisions on their behalf. So if someone does not appoint someone prior to them losing capacity, there is a surrogacy hierarchy laid out by each state. And so I've included Texas's here, and this is also the case in many other states, but some states do vary. So that means that if someone has not identified a healthcare proxy before they become incapacitated, which would be a medical power of attorney, the decision-making would by default go to the patient's spouse. And if that patient, was widowed or was unmarried, it would then go to their adult child or children. And then the next would be the parent, if the parent was still living. And then lastly, the nearest living relative. So you can see just the benefits in choosing someone beforehand, right, to make decisions kind of can avoid dicey situations down the line. In our palliative care rotation, there were instances where, the patient did not have a living spouse, and there were multiple adult children that did not see eye to eye, right? So then it just becomes this whole process of kind of battling it out to figure out, what is most consistent with what the patient wanted. Okay, so I wanted to clear up some misconceptions about advanced directives. One is that the saying that advanced directives are irreversible. This is false. They're not irreversible. So you can change these, you can update them, modify them at any time as your situation changes. Become ill, you want to change, your life-sustaining treatment selections, you want to change who your healthcare proxy is. This can always be modified. Another misconception is that advanced directives take priority. So this is also false. So they're only invoked when you lose capacity, right? So as long as you are, cognitively intact and making your own decisions, like the advanced directive is not going to take precedence. It's what you say. Okay. And so that kind of brings me to what is capacity, right? So simply put, a capacity is a person's ability to make a decision. But for the purposes of this talk and medicine, capacity in medical decision-making is the ability to use information about an illness and propose treatment options and to make a choice that fits in line with your values and preferences. So cognition is obviously the main determinant of capacity. And there's really no black and white, no test that will tell you if someone has decision-making capacity. But what this looks like is usually if it's in question, if decision-making capacity is in question, a clinician will sit down and carry out a pretty in-depth face-to-face interview with the patient and evaluate how they stand on understanding what is going on with their health, whether or not their ability to express a choice about the treatment options, if they can appreciate them unique to their situation. And then lastly, if they can reason. So, do they have the ability to compare options and to infer consequences of a choice? So, if after this face-to-face interview, a clinician says this person has decision-making capacity, then great, kind of ends there and the patient makes their own healthcare decisions. However, if the clinician feels that the patient does not have those 4 decision-making abilities, this understanding, expressing a choice, appreciating, and reasoning, that is when the surrogate decision maker would come into play. So the last thing I wanted to talk about here is this concept of guardianship. So guardianship is the assignment of a legal guardian by a judge. So this doesn't happen very often, but when it does, it happens when, of course, the patient is seen to not have capacity, but they do not have a next of kin or a surrogate. So that's one situation. And then on the other hand, they would, of course, not have capacity, but also there are multiple first-degree relatives who can't agree on an approach to medical care, even after sitting down with the healthcare team and after extensive conversation. So kind of like the rivalry between the adult children and that I mentioned before. So I'm going to now hand it off to Danielle, who's going to start talking about the different types of advanced directive documents. So Danielle, I'm going to stop my share and hand it over to you.
Okay, thank you, Allison. So now we wanted to talk about the purpose of some of the common advanced directive documents and some elements that would make it helpful to know while going through or filling out one of these documents. And so these documents can vary depending on where you obtain them from, but overall they have 3 elements, or they can include 3 main elements. The first being designating your healthcare proxy or your durable power of attorney for healthcare. And this is choosing someone to make medical decisions for you in the event you are unable to make those decisions for yourself. And the benefit of this is that there's a clear choice of a decision maker that the healthcare team knows to go to, and also all the ones who are related to this patient also know that this person is the one to go to. Another element that it can include is a directive to physicians or a living will. And this is more of a detailed explanation of what type of care you would like or not like. And it applies in a specific situation. And so this would be if a person were to be terminally ill and without a chance of recovery and are unable to make decisions on their own. So even though this element is more descriptive, it also is more limited because it only applies in that specific situation. A third element is a do not resuscitate or DNR order. And this directs your healthcare team that you do not want CPR if your heart were to stop beating or you are unable to breathe on your own. And this can apply depending on the document, either in the hospital or out of the hospital. And so many of these documents will contain a few of these. So just depending on the document, these are the 3 elements that it might entail. So when filling out these documents, it's helpful just to be a little familiar with the terminology, because sometimes it can be confusing. But just to clarify, a healthcare proxy is the same thing as a medical power of attorney, as well as a durable power of attorney for healthcare. And this differs from a statutory durable power of attorney, who is someone that someone designates to take care of their financial affairs. And whereas a healthcare proxy is someone who can be designated with one of these documents simply by either getting one from your healthcare team, filling it out, giving it back to them. A statutory durable power of attorney is something that is a little more complex and is usually done through a lawyer. So just to distinguish those 2, a durable power of attorney for healthcare is more along the lines of what we're talking about today. So when filling this out, it's important to know what types of decisions a surrogate decision maker can make. So per the Texas Department of Health and Human Services, surrogate decision makers can make decisions regarding major medical treatments, major dental treatments, and release of records and other information relevant to the treatment or condition that are necessary. However, it does not authorize a surrogate decision maker to make decisions about abortion, sterilization, experimental research, or funds management. Also, in most jurisdictions, this surrogate decision maker should be an adult. It should be someone who's able to engage in complex medical decision making, someone who's willing to act. In many states, including Texas, this cannot be your healthcare provider. And so now we wanted to talk a little bit about the role of a surrogate decision maker and how to choose this person. Some helpful points to just consider it is that this person should be someone you have a close relationship with, someone that knows your values and your beliefs and understands what you would want, someone that you trust, someone who's logical and reasonable. If presented with a complex medical decision, they would be able to have a logical and reasonable way to go about making that decision. And lastly, just practically be reachable, someone who's available to play this role. When considering the accuracy of decision makers, there have been studies that showed that about 68% of the time, a surrogate decision maker made the same decision as the patient would have made. Of course, a lot of these studies were done with hypothetical situations, but still is helpful to see how accurate surrogate decision makers usually or tended to be. They also saw that spouses tended to have the highest accuracy regarding decision making, and adult children had the lowest. And also, if there was an increase in family conflict surrounding the decision, this negatively affect the accuracy of that decision. Some factors that they noted to contribute to accuracy, including having conversations beforehand with the patient or the loved one, having the written documentation such as the Advanced Directive, having shared values and life experiences, the surrogate's beliefs, values, and preferences themselves, and also seeking input from others, all affected the accuracy of the surrogate decision maker. And like was mentioned before, the goal of a surrogate decision maker is basically to make the decision that the patient would have made themselves. And this is referred to substitutive judgment. And this answers the question, what would my loved one want? And then making that decision on their behalf. However, in many situations, things aren't always, life is not predictable, and maybe something that you need to make a decision about wasn't discussed previously. So there's no way to really know what your loved one would want. The next best way to make the decision is known as best interest standards. And this refers to what most people in that condition would want. And so a little more on best interest standards, some helpful questions to ask regarding your loved one to make that kind of decision is, what would your loved one have thought acceptable quality of life was before the given intervention or decision that you are trying to make? And what are the reasonable alternatives to that decision? And what are the likely risks and burdens if you were to elect to have that treatment or intervention? And then what would no treatment entail? Or like what would happen if nothing was done? So all those questions can be helpful in determining best interest for your loved one. Also, as a surrogate decision maker, sometimes healthcare teams come to you with decisions, and if you're unfamiliar with what they're asking for, it might be difficult to make those decisions. So medical terminology that is helpful to know include breathing tubes, and that's basically when a tube is put down someone's throat to their lungs to help breathe for them when they're unable to breathe on their own, and they're hooked up to a machine to breathe for them. The patient is usually sedated with medicines, and so they're unconscious. And this can be used either in a short-term way, And then the patient, can breathe on their own afterwards, or it can be used in more of a long-term way if they're unable to breathe on their own. Another term is CPR, which refers to cardiopulmonary resuscitation. And this is when you press on someone's chest if their heart stops beating in order to attempt to restart their heart. And this often also requires a breathing tube in conjunction. A feeding tube is something that's placed into someone's stomach or their intestines to provide artificial nutrition for them if they, for whatever reason, are unable to eat on their own. And then also in principle, it's helpful to know that treatments do not always equal cures. So a lot of these treatments are referred to as life-sustaining treatments. So they are able to sustain a person's life or their, bodily functions, but do not necessarily mean that they can recover that person back to how they were before they needed those. When making decisions as a surrogate decision maker, it's best to be as informed as possible. And something that's helpful is to have a basic understanding of the clinical course of the chronic illness of your loved one. So for example, some illnesses like dementia can be likened like a slide, where it starts at one level and progressively worsens over time. Other chronic illnesses are more like heart failure, which can be likened to a yo-yo, where sometimes they're doing well for a time, but then they might have a downward turn where they're not doing well and have to be hospitalized, have to be treated, and then again are doing well for a time. So they have this kind of up and down clinical course. Also, it's helpful to know the difference between treating for comfort versus treating for cure. Unfortunately, most chronic illnesses do not have cures. They have managements or treatments that help with symptom management or treatments that can help just improve comfort. For example, in end-stage dementia, patients are often unable to eat or feed themselves. And so one could say, giving them a feeding tube is more of a curative treatment where they can get artificial nutrition. And then hand feeding is more of a comfort measure where you retain the social and cultural aspects of food and eating by having a caregiver hand feed them. And in this case, it's actually preferred to have the comfort treatment versus the quote unquote curative treatment, as it's been found that artificial nutrition actually does not provide benefit for these patients. And hand feeding is much better for their quality of life and just their overall health. So there's treatments sometimes for cure and there's treatments for comfort. Also, futility is a term that might be used. And this is when it's determined that a therapy or treatment that's available for your loved one might not provide any benefit to them. And so it's not necessarily recommended. Also, the reality of CPR is another thing to be informed of. In one study, it found that the survival rate of an out-of-hospital cardiac arrest where a patient required CPR had a 7.25% overall survival rate. And then based on the patient's ages, there was a difference or a decrease in survival rate, especially when you went from patients in their 70s to patients who were 80 and over. And I also mentioned this already, but palliative care is another term that's helpful to know. And this refers to an interdisciplinary service that aims to reduce troublesome symptoms that are surrounding many chronic illnesses, and also provide psychosocial and spiritual support to patients. The aim of this type of care is to reduce distress caused by symptoms and also improve quality of life. And some common symptoms that can be managed with palliative care include pain, secretions, air hunger, nausea. And this is something that is often associated with end-of-life care, but doesn't always have to be just for end-of-life care. As long as there's a chronic illness with troublesome symptoms or a high symptom burden, palliative care is an option for helping to reduce the symptom burden. So as a surrogate decision maker, things that can help this person is to start the conversations early with their loved one. The more time you have, the more information you have, the better. And this is not just a one-time conversation, but something that should be an ongoing conversation, especially when something in your loved one's clinical or like their health changes. That's a good time to revisit this conversation. You are the trusted advocate for this person. And it's also important to take responsibility to understand what your loved one would want. Some questions to help you find this out include asking them how much they understand about their medical situation. Also what they do know versus what they want to know. And also who they want to be involved in decision-making where at the time a decision is needing to be made. From the caregiver perspective in their health, a surrogate decision maker plays a complex role in balancing many competing factors. Not only are they the voice for their loved one, they're also an advocate for them. They themselves have their own values and beliefs that they're advocating for, and they often are not making this decision alone, but they're making the decision with input from many others, so they have to balance those as well. This role definitely can take a toll on caregivers, not only emotionally, but physically, financially, and time-wise. So it helps to have these conversations early and to start, getting to know what your loved one would want towards the time that you need to play this role. And remember that someone will know what you want someday as well. And it's not uncommon for caregivers to switch roles just depending on how life takes these caregivers. So what you do for someone can also be what they do for you one day in return. So in review, we just wanted to emphasize that all adults should be aware of advanced care planning, the purpose of it, the importance of it, and that you're able to nominate a surrogate using those advanced care documents that are available. Adults with chronic illnesses should start involving that surrogate decision maker in the knowledge of their illness, the treatments and alternatives that are available, and start talking about the values that they have, the treatments they prefer. And then once you're an adult with an advanced illness, that's usually the time to start discussing specific treatments that you would and would not like, including those life-sustaining treatments that were mentioned earlier. And so we just wanted to give you some resources. The first is just one of many sites where you can download some of the advanced care documents that are available. The second we wanted just to introduce to you, it's one of many resources out there that can help guide you through having these types of conversations. So let me stop and share that one. Wait 1 second. Okay. So this is a site called the Conversation Project, and they have many resources available. This is one of many sites out there. This isn't specifically the only one you can go to, but it's one type of resource you can use to help with advanced care planning. And then under the Conversation Starter Guide, we just wanted to introduce what it might look like to start having, this conversation, or to start thinking about how you would have this conversation. So this kind of goes through 4 steps, how you could, start to think about what matters to you, plan your talk, start talking, and then keep talking. So for example, for under step 1, make this a little bigger. Step 1 is just to think about what matters to you. So some questions to answer that can help you do this include answering the question, what does a good day look like for you? And some ideas it gave is it time with family or friends? Is it enjoying a favorite everyday activity? Is also, what do you need to enjoy a good life? And what would that look like through the end of life? Another question to consider is what or who supports you during difficult times? Some ideas given were your faith, culture, family, friends, or pets. And then lastly, try finishing this sentence. What matters to me through the end of my life is blank, what? And some ideas were being able to recognize my children, being independent, being able to spend time with the ones I love. So it's just an example of how to even, as a patient or a person yourself, think about how you would start to have this conversation. And we can also send this out to your email if this is something that would be helpful to you. Okay, I think that's it for our presentation, but we're happy to take questions or if you want to share anything or comments.
Thank you, Allison and Danielle. I put the PowerPoint in the chat for anybody that wants to download the presentation. I can also email it as well, but I thought you might want to have it while the presentation was going on. Does anybody have any questions?
I do. This is Peggy. Can you hear me?
Yes, we can hear you.
Okay, since these young women are doing residencies in geriatrics, tell me about the advantage. As I'm about to turn 65, I'm going to need to find a new doctor anyway. Why do I really want a geriatrician? What is going to be my advantages there? Does it matter what can the geriatrician do? Are they going to treat me like an old lady or not?
I can take that, Danielle, if you'd like. So great question. I feel like, you know, my grandmothers and my parents have asked me the same question. So it's a good one to ask. I think, you know, usually a primary care provider will refer their patient to us. So they place what's called a consult to us for specific reasons. So that could be something called polypharmacy, where their patient is on just an inordinate amount of medications and trying to kind of figure out what's most important to the patient, you know, and consolidate that and try to cut down on the number of medications. Another reason could be the patient is falling a lot, you know, not for obvious reasons. So we kind of go through their medications, their living environment, lots of factors to see why they're falling. Another big one is memory loss and cognitive impairment. So we'll be PCPs will send their patients to us to help figure out, you know, how we can help with memory loss, NFC. You know, do they need head imaging? Do they need to go see a neurologist and possibly even start them on some memory specific medications? So that hopefully that answers your question. You know, you seem pretty young and in good shape. It's always a good idea to talk to your primary care doctor too, because they'll usually be the ones that send you our way.
To follow up, I don't have a primary care doctor. She was changing her practice and I don't have one. So as I am choosing Medicare in the next 24 hours, I'm picking these things. And do you go with somebody with geriatrics for a primary or just wait until that extra specialty is needed?
I would say the latter. So Mike, do you want to take that?
Sure. This is Mike Anderson. I'm the residency director for Allison and Danielle. I would say in your situation outside of our VA healthcare system that if you have the choice to pick a geriatrician, I'd go for it. A geriatrician, typically the difference that I see with years of experience doing this is the geriatrician focuses on what matters most to you and how to tailor a specific treatment plan that aligns with your values and your, you know, what's important to you. An internal medicine doctor by default treats diseases, not people and their preferences. If you've got the chance to choose a geriatrician, I'd go for it.
Thanks, Mike.
Thank you. Lynette, did you have a question?
Yes, I did. I know I have some advanced directives somewhere. I actually feel like most, and correct me if I'm wrong, is it not true that most of the time when you check into the hospital for a surgery or whatever, the hospital will have those forms? Is that correct? Okay, assuming that is correct, then maybe my advanced directives are somewhere, you know, at some hospital I used 20 years ago, which isn't very helpful right now. So I guess what I'm asking is, you've given us great resources on where to find these forms and how to fill them out. Where do we put them? Where do we keep them? And is it just, do we just give it to our surrogate and let it go? Or do we keep one on hand? That's just kind of a nuts and bolts kind of question, but it's one I have.
Yeah, I think it'd be helpful to share it with your healthcare team, like I guess your primary care who you see most often. You have a copy yourself, and then also share it with your surrogate decision maker. That's what I would suggest.
And if you make changes in it, you make changes in all of the places that.
Correct, yes.
I would also keep know, at all times where a paper copy is, just in the event that you need to go to the hospital. And it's always good to have a paper copy, especially because everything can get lost in the electronic medical record, and just to be on the safe side.
I agree. I actually have an experience with that where the spouse of one of my friends from church was critically ill in the hospital, and they needed to have that document, and she knew sort of where it was. And I mean, this sounds bad, but we literally broke into her house to find it. And we did find it, but it would have saved everybody a lot of stress, including the spouse, if we had just known where it was and it was with them when they went into the hospital. So that's why I asked the question. I guess I've run into it a few times.
Sure, yeah, it's a good question.
So most of the time when people ask us this question, we're dealing with older people, and there's an assumption that our older adults don't all use technology well. But some of the simple tools that almost all of us have today, as I sit here doing this Zoom meeting on my smartphone, are email and the Google Drive and other things like that. So if you've got a new advanced directive and you've got an alternate decision maker, or maybe you have an alternate to them just in case, there is nothing wrong with scanning that document and have an email that's titled Advanced Directive sent to them. Now everybody's got it digitally where they can reach it at their fingertips.
That's a good point.
Could I interject something?
Sure.
We use Methodist Willowbrook as our hospital of preference. Every time my wife or I have gone to be admitted to the hospital, they have asked us if we had the directive and could we provide a copy to them. So they have a number of hours. It always seems their mode is to ask for another one as opposed to looking in their records. But we also provided them the copies to our primary doctors, our primary care doctor, or cardiologist, who functions more as a primary care doctor than the primary care doctor does, and pulmonologist, just the key doctors that you see most often.
Sure.
I have a question. So I take it that Texas website, the first one you listed, probably has some, what do they have, some model forms that are acceptable. But what about if you use like a software program like Willmaker or something like that? Are those generally accepted in the medical field? I mean, as long as you've signed it and everybody understands it?
Yeah, I'll take that, sir. If you were to bring us at the VA hospital something done outside of our system and it had two witnesses or it had notarized signatures with a notary public seal on it, we certainly would accept it. And in Texas, one key point to the two witnesses is the two witnesses can't be the people you're appointing to be your decision makers.
Thank you.
Absolutely.
I think sometimes they can't be medical care personnel either.
Correct. Mm-hmm.
Do the documents also have spots for give my organs or that part? Or is that a different set of documents?
That's a great question. I'm actually not sure. Mike, in your experience, have you seen that ever built in?
So it's going to depend on where you find your forms, whether or not they list this. But typically, the best way to ensure that you're honored as an organ donor is to do it through your State Department of Motor Licensing. Make sure your driver's license lists you as an organ donor. And if you're really interested in being an organ donor, you may even want to work with major hospitals in our local area that have big programs for this, and already be pre-registered with them for that.
In the website you talked about, does it go into, as long as you're talking about these issues, also talk about what to do with my remains and all that? Does it follow the next step?
Not on those specific forms. There's also a question in the chat that says, are copies legal? I'm guessing this means copies of the advanced directive document.
Oh.
Absolutely. Most of the time, hospitals realize they're not going to get the original.
Does anybody have any additional questions? This has been really helpful. Thank you all. Thank you, Mike. Thank you, Danielle. Thank you, Allison, for joining. I think we've talked a lot about the documents, but I feel like the most important thing is the conversations and making sure that your family knows what your wishes are and vice versa. The documents are great. It protects you. It puts it in writing, and you definitely want to have those. But I think the bigger thing that Danielle and Allison touched on was making sure that you have these conversations with your family so that they know in the event that you can't find the paperwork, they will default to whoever the power of attorney is, and they will be able to communicate what your wishes are. So I just want to reiterate that part.
I also want to thank everybody for the presentation today. It was really informative, had a lot of good information. And I think you'll see in the chat, and I think Ariel mentioned it too, we all have copies of the slides, which I'm going to print out because I think that would be really helpful. So thank you again for your Sunday afternoon and your sharing your knowledge with us. We appreciate it.
Thank you for having us.
Yeah, thank you.
All right. Hope everyone has a great Sunday.
I'll do the same.
Thank you all so much.
Bye.
I'll be sending out the recording as well. Y'all have a wonderful day.
Thank you. Bye, guys.
Bye.
Well done, ladies.